The Metro on 97.3 FM, Supertalk, Mississippi.
Good morning, Central Mississippi. It's time for the Metro on Supertalk Jackson 97.3, and it's a beautiful
What do you say that?
morning in the Metro. Not a cloud in the sky.
Let me tell you a secret.
Yeah.
They're all beautiful mornings.
Well, sometimes there's ugly clouds in the way, and there's traffic jams in the way.
Well, it's still a beautiful morning.
But today, particularly, February 27th, 2020, it is a beautiful yet chilly morning here in the Metro. And if you did or are still driving into work, you're probably thinking the same thing.
You're late.
Late? What do you mean late? No. I'm not late. I'm here. I am right on time. No. Well, you may not be late. There's people who go to work at different hours, Perez.
I wouldn't know.
You wouldn't know. No, you're here before us all the time. And anyway, so it was a beautiful morning. I just wanted to pay homage to the crisp, cool air and the bright sunshine because it always puts you in a better mood. And something else that's probably going to get you in a better mood is me introducing you to my guest who's joining us here on the Metro. Now, it's Dr. Charles Ramsey, and he is a trained dentist, but he's not your everyday dentist. He's also dedicated to treating and maintaining your sleep and pain-free days, which to me are two things that I don't think get talked about enough. You have been in the dental profession for over 30 years, but you have the knowledge to heal and the wisdom to listen, and I love that. Whoever wrote that for you, it was absolutely beautiful. So welcome, Dr. Ramsey.
Thank you for having me.
And I will call you Charles because that's what you asked me to do, but
Yes.
I had to do the proper Southern things first and acknowledge you. Okay, Charles, so let's go back to the beginning, at least into dentistry. What got you interested in being a dentist and practicing for as many years as you did?
Well, I guess in college, I really thought I was going to do medicine. Mm-hmm. And I went to college on a baseball scholarship. And after my second knee surgery, that ended. So I went to work in the operating room of a local hospital working for the anesthesia department. And at that time, in the late 70s, early 80s, medicine and hospital shows on TV were glamorous, and it was just a great life. And the more I was there and the more I listened, and one of my mentors said, do something else. And they did, and that sounds crazy, but, and then my older brother, who is 17 years older than I, was a dentist. He's retired now. But I began thinking about, he loves what he did. I mean, he was interested in doing more and better in new technology. And I didn't even talk with him. I just applied to dental school and called him when I got in. And so my initial thought, I would go to dental school and do oral surgery because I liked the theater in the operating room. And this is going to be odd too, but in my third year, cutting teeth was the most fun I'd ever had in my life. It was just it was odd.
Stop
I know.
now. You're
I know. Perez, I'm going to pick you up off the floor probably, but I did. Cutting teeth was just so much fun, and having the ability to control pain. One of the gurus in the world on local anesthetics, his idea is if you control anxiety and fear first, controlling pain is pretty simple. And it's right. I mean, that,
and that's in anything.
In anything. And so we actually do teach our students. I'm not full time at the school any longer. I'm part time, but we really emphasize sitting and listening, talking with patients, and because most of them have some degree of fear.
Especially when it's talking about coming to the dentist.
Exactly. We're invading their private space. Maybe they had a poor experience as a child. Maybe they've heard stories. But I just feel like, dentistry is the greatest profession. I enjoy dentistry. It was good to me and my family, and I really loved dentistry. I did that for 23 years. And
And then you made this unique transition, this huge pivot to pain management and sleep. I guess maintaining or sleep management and pain management. I guess is a good way to say it.
Exactly.
So there had to be a aha, come to Jesus, epiphany, some point in your life to get you, from going a great career in one direction to pivoting to another. Still form of medicine, still helping and healing, just in a different direction. So what happened in your life to shift that for you, Dr. Charles?
Well, in 2010, practicing dentistry, I began to notice, like many of us, we have carpal tunnel problems. Surgeons do, hygienists, dentists, anyone that does repetitive things. And so I began getting numb and really just thought, okay, it's just carpal tunnel. I would shake my hands, finish a root canal. I took more and more Motrin, more than I ever, I didn't realize how much Advil I was taking every day. And it was Christmas of that year. I'm a redneck, complete redneck. I hunt and fish, and I wasn't hunting a particular day during the holidays. I was watching football and realized I was completely numb to my fingertips bilaterally. So I knew it was my neck and not my hands. And so ultimately, it's a convoluted story, but my spinal cord was squeezed at 2 levels in my neck. And I did have surgery. I'm grateful for it. Prevented me from being paralyzed. And so for a couple of years, I didn't know who I was. I lost my identity. I'm a Christian. I have strong faith,
professional identity.
But I didn't know who I was. Am I a dentist? Am I not? I can't practice, so I guess I'm not. And questioned my worth. And so fortunately, I had treated pain as a dentist. I just enjoyed it. It was rewarding, but you have to do that on your own. We didn't learn that in school, really.
Right.
And so another thing happened. One of my patients he's retired, but he's a psychiatrist, and was over the sleep clinic at the university. Matter of fact, the physician who's over the sleep clinic, it still falls under psychiatry. But he invited me while I was recuperating from my surgery just to come watch. And it was fascinating. We never learned anything about sleep. And really, honestly, up until less than a decade ago, no one really talked about sleep, whether it was at a dental meeting or even medicine. And there's just been this explosion now
of research and sort of connecting the dots too when it comes to your sleeping habits being a part of the wheel for wellness.
Yes, it is. Yeah. And really, the greatest research has only been done the last 2 decades. A guy by the name of Matthew Walker, he's a PhD, has a book out. It's not a text. The public could read it. It's called Why We Sleep. But until about 20 years ago, that question wasn't even answered.
You just did.
Yeah, we just did.
Or didn't.
Yeah, that sleep just meant you weren't awake.
Right.
But it's an incredible world of how sleep influences everything. And so in my practice, which it's an unusual practice, to my knowledge, no one in Mississippi has done this type practice. There are only a few in the country, but I treat pain, head and neck pain. That may be headaches, that might be muscle pain in the neck, but I treat pain. And I also, if a patient, for instance, is diagnosed with obstructive sleep apnea, and in this country, a physician has to do that, a dentist can't, but they're often prescribed a CPAP to wear, which is the number one go-to for obstructive sleep apnea.
Which sort of makes sure it forces air in you, right?
Exactly.
To make sure you don't stop
breathing. It's positive
breathing.
Air pressure. That's right. And so it's continuous. And so it helps to open the airway and greatly improves quality of life. Now, if you look at, and I don't know how deep, I may get out into the deep grass and stay. You got to get me back in the fairway.
I'm enjoying it here on the Metro.
But oftentimes patients cannot tolerate a CPAP.
Is it because it's just an obstruction to try to sleep? I mean, for me, I can't even wear, we were talking about earlier, like the little Fitbits that do I can't have anything on and that I can't go to sleep with. Unless I'm exhausted.
Yes.
Yeah.
Well, claustrophobia is certainly an issue. Now, initially, there was a large mask that patients had to wear. That all has been improved, but still, you do have straps. You do have some binding on the face. Mm-hmm. You do have tubing that may restrict movement during the night.
You can't be a face sleeper or a back or side sleeper and all that.
Some patients, it's the airflow. So there are a variety of reasons why the CPAP, even though it's the most efficacious technology, that means how does a device function under ideal conditions?
It does well, but it doesn't help everybody.
That's exactly.
And there's probably people who it helps, but maybe other alternatives would get them free from it.
Yes, exactly. And so really you have the CPAP as the number one. There's a limited number of patients that can have a surgery called Inspire. It's similar to a pacemaker that's implanted. There's a sensor in the chest wall, and then a wire is actually threaded through the neck and into the hypoglossal nerve, which controls a muscle that pushes the tongue. So it will force the tongue forward
to keep your airway open at night.
It's called Inspire. It's just a limited number of patients that qualify.
Seems very extreme too.
Well, it is a surgery.
Yeah.
And now statistically, patients do extremely well, very low risk of infection or complications, but there again, it is a surgery. And you can get as radical as having the oral surgeon move jaws. That's pretty radical, but that works.
That's radical.
That's radical. That is real surgery.
That is real surgery. You'd have to be really sleepy to want to go through that, or have your house.
Your life is threatened.
Your life is threatened for that. Yes.
You've lost quality of life, and you have. Your life is threatened,
right.
And so sometimes radical measures are needed. Now, what I do, and I am not the only dentist in Mississippi that does a sleep appliance. There are 3 of us in the state who are board certified in dental sleep medicine through the American Board.
I didn't even know that was a thing.
Well,
but when you start talking about the fact that it's your tongue and your airway and sort of all of that, or even your jaw, that may be hindering your quality of or your ability to fall asleep and stay asleep because of air, it makes total sense. I mean, you guys know the mouth better than anybody.
And it really does make sense. Matter of fact, only dentists can do the oral appliances. Physicians can't. And but
they have to make the.
That's right. They
have to prescribe it.
They make the diagnosis and prescribe. Exactly. There's a protocol for us of what we need from the physician, and which is easy to get, and but we need that theoretically for us to perform the procedure on the patient. But so. There are 3 of us that are board certified in Mississippi. There probably aren't quite 500 in the world that have a board certification. Now, are there dentists treating sleep apnea with oral appliances that aren't board certified? Yes. I don't know how many there are, but there are some other dentists that they go to just some CE courses and are doing appliances. So.
It's a question that you just need to have in your toolkit to ask if that is something that is important to you.
Yes.
I mean, it should be important to you, but I don't want to throw anybody under the bus. So if you are, or if you want to think about and you ask your dentist, just ask them if they are have that board certification.
That's right. And dentists, we are teaching now dental students to screen for sleep apnea. I even teach hygiene students to do it because really hygiene students are the more ideal. They spend more time with the dental patient
they do.
Than the dentist does. And so I still teach in the hygiene program, and I do lectures for them.
How many do you feel like those that struggle with sleep, because typically you hear, and this is painting with a broad brush and just all the stereotypes, right? But typically you see those with sleep apnea. They're going to be overweight or smokers or, fit like a certain sort of, description, so to speak, physical description. But is that too stereotypical? Are there people who maybe don't smoke and are the right weight and all of that also can struggle with sleep apnea and the things that sort of surround that?
That is I don't know how in the world you had the insight to know that, but
well, because you can be skinny and have bad cholesterol and still die of a heart attack.
But no, you are exactly correct. The stereotypical is an overweight person, and only about 50% of sleep apnea patients are overweight. Now, a 10% weight increase will affect your chances of having moderate to severe obstructive sleep apnea by about sixfold. It also raises it's called an AHI. I'll tell you what that means in a minute, but it raises your index by 32%. And that's only a 10% weight increase. So weight radically changes, particularly for men, because we tend to get fatter centrally. So
neck, face,
that's right,
and
neck,
broader shoulders,
that's right.
down to that.
So,
women carry it more in our rear tail and bottom area.
Exactly. That's it. That's exactly right. But men.
That doesn't stop shaking your head at me, Perez. That doesn't obstruct your sleep the same way as a thick neck does.
No, it doesn't. That's correct. That's correct. But so only about 50% are actually overweight. Yeah. Now, about 1/3 of all patients tested at our sleep clinic at the university, it's actually on Ridgewood Road, but it's the university, they're 18 years of age and under.
Really?
Yes, they are. Yes, and your point or your question about is it all stereotypical? It is not. It really isn't.
So we are going to continue our conversation with Dr. Charles Ramsey. He is not your everyday dentist, but he spends his time helping you maintain good sleep and pain-free days, which I think we can enjoy, coming up next here on the Metro.
I can't stop the feeling. Nothing I can see but you when you dance, dance, dance. Feel the good creeping up on you, so just dance, dance, dance. All those things I shouldn't do, but you dance, dance, dance. Ain't nobody leaving, so keep dancing.
I love this song, Press. I still go back to every time my little 5-year-old at the time had her little dance recital of this song. And every time you play it coming into the metro, I pause for a minute and I see her in her little hot pink and purple outfit doing the little troll dance.
Oh, okay. That's cool.
So
That's a nice memory.
If you see me sort of pause when that song comes on, I can see her shimmying and twirling because, you know, as a good parent should, you should know the routine because you've heard the song 1,000 times. So much so, Dr. Ramsey, sometimes I see that dance in my sleep.
I bet.
Which we are continuing our conversation with Dr. Charles Ramsey. He is a dentist by trade, but he spends most of his time or all of his time now in practice helping you with your sleep and pain management, which I want to make sure we spend the majority of the time on. So you left us sort of just talking about the fact that there are no stereotypes when it comes to poor sleep. So if you know without a shadow of a doubt that you're not getting adequate sleep, then you need to address that, correct?
Oh, absolutely.
And learn why.
Yeah, up until really 2 decades ago, the idea was sleep was, well, we're just not awake. And that is completely wrong. Sleep affects really everything, even physiologically. There is a strong correlation with obstructive sleep apnea, with hypertension, cardiovascular diseases, type 2 diabetes, certainly being overweight. And here's the one thing about, I think we did mention weight, maybe it was during the break, but nearly every disease that a patient walks in with,
especially chronic.
That's right, chronic. It's, okay, we got to lose weight. Well, yeah, it's like telling a drug addict, well, just quit. It's a difficult task for many people. And one thing that happens physiologically with lack of sleep or poor sleep, particularly obstructive sleep apnea, there is a chemical called ghrelin that's produced by the gut. It tells us we're hungry. When we get interrupted sleep, or when our sleep is poor because of obstructive sleep apnea, we produce more ghrelin, telling us that we're hungry. There's another chemical called leptin, which tells us not to eat. It goes down in production. So we're telling the patient, look, we want you to lose this weight so it will help your obstructive sleep apnea. But the fact is, if the obstructive sleep apnea is left untreated, they're likely not
It's going to be an uphill climb when it comes to the sort of the way
to lose that weight.
And it feels like for many who get frustrated with trying to manage their chronic ailments, Dr. Ramsey, whether it's the blood pressure, the cholesterol, the weight, the diabetes, or whatever it may be, they're not getting a whole lot of conversation about, well, you're doing all these things right, but what does your sleep habits look like? Because it's kind of the icing on the cake, so to speak, or you could almost say it's the foundation of it all. Because if you could do all the right things, but if you don't have that restorative sleep that's consistent, you are going to have a harder time reaching your other goals.
Oh, there's no doubt. And physiologically, there are multiple reasons why that happens with interrupted or even obstructive sleep apnea. But just for an example, one study looked at teenagers and young adults who were diagnosed with schizophrenia. Well, statistically, it was determined that they had a 2 to 3 times less volume of deep sleep. That's non-REM type 3, stage 3, but that's when we go in our deepest sleep. It's not REM, that's the deep sleep. And so they were not getting enough of deep sleep. And so there's a strong correlation in that book that I mentioned.
While We Sleep.
While We Sleep. Matthew Walker says that every major mental disease is tied to sleep. It really is.
And that's on the spectrum. So if you deal with anxiety or worrying or bouts of depression or,
Yes.
or even if you feel a little bipolar some days, even if you're not clinically ups and downs and manics, you should stop and think about are you getting this? Would you consider yourself rested?
Exactly.
I bet the answer is hello, no.
Well, there again, mothers are being a mother is the most difficult job that God ever ordained.
And also shift workers. I know
And shift workers, yes.
Because we have a lot of healthcare professionals as well as, Nissan employees, as well as just a lot of people who work weird and crazy sort of radio producers and
Radio
hosts.
people
Radio
work
people work
all the
crazy
time.
hours.
Yes,
There's some
yes.
of us that don't, but a lot of us that do, and that can do it. Okay, so we need to get to the solution part, Dr. Ramsey, because I know there at your clinic you keep talking about obstructive sleep apnea and the way that you guys can help sort of screen for that. So if I was to come in and I had these concerns, tell me what's going to happen next in terms of you figuring out what's wrong with me.
Okay. If I see a new patient, they on our website will indicate are they coming for pain or are they coming for sleep issues. And so before they get there, I have some idea. There are times when it's the chronic pain that is interrupting the sleep. Chronic pain can cause depression and anxiety.
Absolutely.
Depression and anxiety can cause chronic pain. And so interrupted sleep, also the same. It's hard to separate pain and sleep. So it's my job to evaluate the patient. First, I evaluate all their muscles. I listen to their joints with a stethoscope. We do some motions. And so I get a picture of what's happening physically with them to see what's causing their headache. We treat headaches, we treat neck pain. So I get that solved, and I do that exam whether they're coming for sleep or not, because oftentimes it's the chronic pain that's interrupting their sleep. Now, let's just say if the patient's coming in, they've been referred to me from a sleep doctor. And there again, only sleep doctors can interpret the sleep studies, but they send them to me
Right.
because the patient can't tolerate a CPAP. Then I will do an exam of their muscles. We'll discuss pain. Is pain even a part of their equation? And if it is, we treat that with trigger point injections oftentimes. If it isn't, we go ahead and schedule them to have impressions taken. We register a bite in a particular way that moves the jaw forward. Now we're opening the airway not anterior, posterior, but more in a lateral dimension. And so, but we get all of that sent to the lab. A lab in New York actually does our sleep appliances. And then the patient comes back, we get it all adjusted. And I actually see the patient about 11 visits total. That's protocol. And so the oral appliance is much better tolerated more effectively than the CPAP. Now, physiologically, there's much literature about the effectiveness of the CPAP helping with everything from hypertension to cardiovascular diseases, type 2 diabetes, the very same results as the CPAP. What I can't do that a CPAP does, I mentioned a term, AHI, just a few minutes ago. That's the apneic-hypopneic index. When a patient goes for a sleep study, they monitor the entire night, and then they divide the number of apneic. Apneic event means that at least 90% of the airflow has been shut off at least for 10 seconds. Now, hypopneic means that at least 30% of flow is cut off for at least 10 seconds, and the oxygen goes down at least 4%. So those are the criteria used. So they divide that into the number of hours, and that's your AHI, your apneic-hypopneic index. We would love to get people to 5 or less events per hour. That's ideal. If the patient is from 5 to 15 events, that's called mild sleep apnea. If it's 15 to 30, that's moderate. Anything above 30 is severe sleep apnea. And so the thing I can't accomplish most of the time that the CPAP does, CPAPs have the ability to get the patient down to pretty much normal. With the oral appliances, about a third of the patients I treat are not going to get to that norm, 5 or less. Now, we're going to make them better.
They need the oxygen. They just need the extras.
Yeah. And sometimes there are multiple reasons why people have apnea. It can be all obstructive. I do best with that with the oral appliances. Sometimes it's a central problem. It's a brain issue. It may be a neurotransmitter problem, or it may be that the muscles that are controlling the airway aren't responding well to what the brain's telling them. And so there are multiple reasons why people lose that airway.
That's actually, so you can't just put people in a silo or sort of check a box and sort of move on. It sounds like this is, you're looking at the whole person there.
Yes.
Dr. Ramsey, to sort of figure it out. And at the end of the day, what you're wanting is just people to have meaningful sleep and then also those pain-free days. If we want to come in, we don't need a doctor referral just to come in and have a visit with you, correct?
That's correct.
Okay, so
most of the time it is referral. For instance, if it's a pain patient, that normally comes from a dentist, ear, nose, and throat. They are usually very good. Patient comes in with an earache, and they examine the patient. The ears are clear. They send them to me because they know it's temporomandibular disorders. So I get a lot of referrals from ENTs for pain. And then most of my sleep referrals come from sleep doctors.
So if we're listening to the Metro and we feel like we would fit your bill, but maybe we're not sure which doctor to see, can we at least check your website and call and talk a little more, and then you share where they should go next? Because I think there'll be a lot of light bulbs going off about maybe there's more to my issues than just what I feel or self-diagnosed or my current physician or doctor saying, and would like to at least know what my next steps or my options are.
Oh, absolutely.
What's your website?
The website is MS-Pain and, spell out the word and, sleep.com.
And it's hard, and it goes back to what I've learned from you today, is that pain and sleep cannot be easily separated.
Exactly.
So you can't have most of the time you have like one sort of with the other, and that we all should be doing our best to get more quality, restorative sleep. What's the one thing we could do tonight to get a better night's sleep, as long as it's not obstructive issues?
No iPad.
Dang.
Oh.
I was like, no alcohol. I was like, I gave that up for Lent.
Yeah. Well, actually, I can't. Alcohol is the. Oh, is it?
Yeah, alcohol, and iPad, all the things that we have heard. Dr. Ramsey, this has been so much fun. I know we'll have you back here on the Metro. I hope people reach out to you to get their restorative sleep, but stick with us. We're shifting gears coming up next here on the Metro. Just let you have your share moment. I need everybody to have their jazz hands out. It's almost Friday, guys. It is almost Friday, and the weather is beautiful, even though it's a little chilly here in the metro. And you may be thinking about warmer days ahead. Typically, with warmer days in spring, comes putting your house up for sale.
Or spring cleaning.
Or spring cleaning, or whatever that may be. So we're going to have a good conversation here on the Metro with Rebekah Whittington. She is a realtor, but I love that your former life was a school teacher. So you really, you went from one extreme sort of to the other. But I think this is a good conversation for you to start thinking about now when it's cold, right? That we're gearing up for great or better weather, because I feel like, never been a realtor, but is the summertime your sort of spring, summertime, your busiest seasons when people are ready to sell versus buy and sort of all of that?
Most definitely. For a couple different reasons. I mean, obviously the weather's nicer, but
so it's not just the weather.
No.
So what are the other reasons that summer is sort of prime season for you guys?
Well, you have people with kids who are in schools, and they may want to change school districts. So that's the opportune time to do that and get in and get settled before school starts back the next year.
So selling or buying a home can be one of the most painstaking experiences of your life, Rebekah, and you are holding people's hands as a realtor sort of going through this. My husband and I have bought twice, only sold once, and I swear we're going to die in this house because the process can just be, sort of overwhelming, right? And I remember when we got our first house up for, or our only house we've ever sold up for sale, it was a rude awakening to me on what all had to be done, which I thought we were doing a good job taking care of, living in our home, right? That needs to be done to make it presentable for buyers. I always tell this story, Rebekah, where my oldest daughter, she wasn't 2 yet, so she was somewhere between 1 and 2. And when the first person came to look at our home, the comment they left were dirty baseboards. And I broke into tears because I worked from home. I was also a full-time mom, and I'm like, who has time to clean their baseboards?
Right.
What butthole is looking at the baseboards? But apparently, people who don't live in your home want to see their potential home as clean and spotless sort of as possible. Okay, so I'm giving you the stage, Rebekah. When you take on a client and you walk through their home, what are you telling them to think about in terms of getting their home prepared for selling?
Well, this is probably one of the hardest things or hardest conversations to have because you live in your home. I mean, I have kids. They're messy. I don't feel like coming home and cleaning every day. Neither does anybody else. So, the main point that I like to try to make is, keep the goal or keep the end in mind, and what's our goal here, and that's to get the house sold. And you don't see things that other people that aren't coming in your house every day notice, and so that's kind of where I come in, is trying to point those things out. Decluttering, depersonalizing, because you want buyers or potential buyers to come in and be able to picture themselves in your home.
All of those cute artworks and things that's covering your refrigerator that's a prized possession to you, buyers don't give a darn about.
Right.
You have to take. I was very offended by all of this in the very beginning when we sold our first home, Rebekah. So I can appreciate a realtor who comes at it with kindness.
Yeah, and you just kind of have to keep in mind too that it's just a temporary thing. You're doing this to reach your goal, and once it's over, you're in your new home, hopefully, and settled, and all that can come back out. Until the next time.
So let's talk about like the different paints and stuff. Should you go to the extreme of maybe you do have a teenager who really want to express themselves and they put hot pink or, neon green paint up or whatever it may be. Do buyers today really care about things that they can easily change, or is it important from the seller's perspective to go ahead and knock those out with a coat of paint that brings it back to normal?
It just kind of depends. If it's like hot pink, I would definitely recommend that you paint it. A lot of buyers have a hard time coming in and picturing the potential of a home. And so it's just like, anything, you want to put your best foot forward. And so you want it to look its best. And typically that's, you're going to get the trade-off of you're probably going to get more money. It's going to, bring top dollar, especially if it's something that a buyer can picture as move-in ready. The more things that they see they have to do, the less they're going to want to spend initially, on the house, because in the back of their mind, they're going to have to be putting money into painting or, building a deck, whatever it may be.
So from from a buyer standpoint though too. So if you are looking for, you don't mind doing a little work. So say take somebody who, like my parents for instance, they've lived in the same house for 37 years or 32 years. They haven't done a darn thing to it other than keep the bones well. They've kept it up, but there was no renovation, so you can only imagine what it looks like, when you walk in. There is so much that would need to be done to bring it up to date, right? But they're on, several acres in a good school district or whatever. Would you advise those types to maybe be more realistic with their asking price and leave the wiggle room for the new tenant to do as they want? Because I feel like the seller's never going to put in the money that maybe a buyer would if it was their home for renovations.
Well, you're correct. And, kind of the mindset of that. I mean, there are little things that you can do that are very inexpensive where you will get a good return on your investment. And then, there are other things that I, as a realtor, would not encourage you to do. And then just reflect that in the price, knowing that, the potential buyer may want to come in or may be able to come in and do those things and things that you wouldn't necessarily get a good return on your investment for. I would not advise you to even spend the money to do that.
So this is the good thing. You should have a relationship with a realtor. So Rebekah, you can talk about, in terms of real estate or being a realtor, what should we be asking the questions from our realtor for before we even hire one? Because really just because you call on one doesn't mean that they're yours, right? It's a relationship that you have to build. So what should we be looking for in a relationship, whether we're buying or selling in a realtor?
Well, our primary, I guess you would say, objective, my role is just to mainly educate my client. We know the laws, we know the rules, we know the regulations. And so, we're just kind of there to advise them, tell them what's normal, what's not. One thing that I always, like to go over when I go meet a potential client and, discuss listing their house is our marketing plan. How are we going to get your house out there to where people are going to see it and know that it's for sale? So just kind of those things.
I've never thought about a marketing plan, so to speak. So do you specifically work in a certain area here in the metro, Rebekah, or are you kind of where people need you?
Well, in Mississippi, when you become a licensed realtor, you can actually sell anywhere in the state. I am from Brandon, Rankin County, and so that's primarily where I work, simply because that's what I'm familiar with. I know that area really well. I do expand out into neighboring counties like Madison County. I actually live now really close to Simpson County, and so I've become more familiar with those areas, as I've been selling real estate, because we spend a lot of time out and about, driving around, meeting clients, showing them houses. And then, there's research that I've had to do that has, about different areas that's taught me or helped me learn more about them.
What are some of the mistakes you see sellers make? Or buyers, because that was going to be my next question.
Yeah. That's a tough one. I mean, I guess it can be kind of like a frustrating aspect of our job is, we consider ourselves the expert. And sometimes, the process of buying and selling, it's a very emotional experience for some people. I mean, someone may have lived in a home for 25 years and there's a lot of memories and a lot of emotional connections. But, there again, you have this one goal in mind. And so buyers and sellers, they don't always take our advice. They don't always listen to, what we, the expert, have to say. And so that can kind of affect things and make it a little more difficult for us. But there again, the big picture is, just that getting to that end result, maintaining that relationship, building that relationship, and then just making your client feel comfortable with and trusting what advice you are giving them and what you have to say.
Well, you're right in terms of the emotional part of it because, just thinking of terms of my parents who have been in a home for 3 decades. My dad is very emotionally attached to that place, right? And so he's going to get offended of anything that someone comes in and doesn't necessarily like, right. Way more than the baseboards. And we were only there for 2.5 years and sort of in that respect. What should people, because the weather's not really great right now, but in terms of that that plan, is there anything we can start doing, or maybe the first step is just researching a good realtor?
Yeah, I mean, that's kind of where we always suggest, a person start is find you a good realtor, because they're going to be able to come in, take a look at the house, meet with you, discuss their marketing plan, discuss the things that they think you need to do. But, as far as, I guess just like a broad thing, or that would apply to anyone that's getting their house ready to sell, it's just declutter, and this is a great time of the year to do that. The whole spring cleaning thing, just things that you don't use every day that you may not need in the next 2 or 3 months, however long it may take you to sell your home.
Well, Rebekah, if we need to sell our home, how do we get in touch with you?
I am with Havard Real Estate Group, and we're in Pearl, Mississippi. The office phone number is 601-340-9656, and my cell is 601-941-6245.
I feel like we're going to have you back closer to the springtime.
I'd love to.
All righty, stick with us. You got more coming up next. The JT Show, hosted by Dave Hughes. You'll have In a Mississippi Minute at 1. I'll be back at 2 with good things, and you can round out your day with Sports Talk Mississippi. But until next time, guys, have a great day.